Welcome to the Black Doctors Speak podcast. I am your host, Dr. Renee, and today I'm really excited. We have a really amazing guest, Dr. Catherine Tumer. I'm going to let her tell you what exactly she does, but today we are talking about an extremely hot topic. We're talking about GLP-1s. So please make sure you share this podcast wherever you're listening to it. If you're watching us on YouTube or anything, please share it because this is clearly a hot topic. I just literally read a post on Facebook and the person said, oh, that's that Ozempic body or something. So this is something that everyone is talking about. And we want to make sure we get to the bottom of it so that we as our community understands it. So Catherine, thank you so much for being
Oh,
here.
you're welcome. Thank you for having me. So, as you said, I'm Dr. Catherine Toomer. I'm a family medicine and community health physician, and I'm founder of Total Weight Care Institute. And what Total Weight Care Institute is pretty much a two-pronged program. One, to provide compassionate and complete care to patients, and then the other is to provide training for physicians and their mid levels for complete and compassionate weight care. And the reason that's so important is because any of us who have been obese, like I have 100 pounds ago, um, we get shamed a lot. And so having that compassionate care is really important in our success.
Definitely, definitely. Pictures. So this is picture Catherine before and after, Dr. Catherine Tumer before and after. And here is some before pictures of myself. So, as you can see, we know a little bit about weight loss, just a little
Hmm.
bit.
Just a little.
So,
Hmm.
okay, so please, can you tell us? I really want people to hear your story of how this started, like how you got into this,
Okay.
because that's amazing.
Well, 23 years ago, I almost died. So that did it. Um, I was I had gained weight consistently through stress related eating, stress related metabolic issues. Ended up a type 2 diabetic on insulin, and was 100 pounds, more than 100 pounds overweight. And then a month after my daughter was born, I went into congestive heart failure, which is actually not unusual for Black women. Unfortunately, it's rare, and mine was missed. So I was misdiagnosed with pneumonia. So I walked around for 2 weeks, thinking I had pneumonia and being told that my shortness of breath and my fatigue was, I was an obese woman who just had a baby, basically, is what I was told. So when I was diagnosed with congestive heart failure and told I had a 50% chance of living 5 years, I decided to do something about it, but I couldn't do anything about it with my heart. So I said, okay, well, I'll work on my metabolic process and I'll work on my weight. No one would touch me. Everyone just said you're too high risk because of your heart. Focus on your heart and let everything else fall into place. But I knew if I didn't get off insulin, there was no way I was going to be able to reverse what was happening. And so I just created my own plan. I started documenting everything I ate. I started checking my blood sugars incessantly. And so what I worked on getting my diabetes under control, and I did rather quickly. I was able to come off insulin and my weight dropped by about 60 pounds. Now, this was 20 some years ago before we had made the connection between metabolic health and weight health. So when that happened, I immediately thought, well, wait a minute. How did it that I got my diabetes under control and I lost weight? And we've always been told lose weight and then your diabetes will become controlled rather
Right.
than the other way around. And so when I was able to go back into practice, which was about 9 years, it took about 9 years for my heart to recover well enough. So I went back into practice. I started using my program with my patients and it worked. The problem was is that I was working in a community health center with few resources and little time. It wasn't diabetes. Everything was focused on diabetes as a metabolic issue, but there were other metabolic issues that lent themselves to health issues that nobody would let me do. So I left and created my own practice. And that's what I've been doing ever since. And I had a brick and mortar until the pandemic, and I went virtual, 100% virtual, realized it increased my reach. And so I stayed virtual. And so that's what I do now.
Awesome. So you hear that, everyone that's listening or watching. And for those that are listening, you might want to check out the YouTube so you can see the pictures. But for those that are listening or watching, wherever you're at, she is virtual. So you might be able to work with her and get off of your medication. So you were a type 2 diabetic.
Yes.
So that one, in case no one, that's listening, in case you didn't know, type 2 diabetes is something that you can actually work towards getting off of insulin.
Yes.
This is not something that you have to live on forever necessarily. Type 1 diabetic, it's something totally different metabolic process, totally different. But type 2 diabetes is something that a lot of those people can go into what they call remission and they don't have to take medications anymore. So that's something definitely to work towards. But you, I know, have said that you've been using GLP-1s for a very long time.
Yes.
Before Hollywood started and everyone started
Yes.
talking about that.
So what happened? I actually was able to come off all diabetic medication, and I was able to control my diabetes just through diet. And I couldn't exercise because my heart wouldn't allow me to. So it was just diet alone. As I got older, that became harder and harder and harder. And so I have gone back on medication for diabetes. Now, about 10 years ago, my ejection fraction, which is what we use to measure congestive heart failure, started to deteriorate. I got up into normal range on medication, but then it slowly started creeping down. My very wise and very progressive cardiologist put me on a GLP-1 to preserve my heart, to preserve my ejection fraction. But because I was a diabetic and because I had so many underlying metabolic issues going on, my weight dropped. So it was not intentional. It was a secondary, I don't know if you called it benefit or what, but it was a secondary reaction to the medication that I was put on for my heart. And that was about 10 years ago. So I started using it with my patients more and more who needed to get their metabolic status corrected and who had weight issues, who needed weight management. And I found that it worked. And so I kept doing it. Now, this is before Saxenda came out, where we were told it was for weight loss. So I was using it in my patients beforehand when it was still easy to get and insurance companies hadn't caught on. So it was nice. And that's what, so I've been using GLP-1s for weight management for over 10 years. And the reason they work is because our fat production, our weight gain is a metabolic process, just like diabetes. So that's why diabetes medications work so well. And one of the things I often ask, and anyone who hears me talk hears me ask this question: if you take Tylenol when you don't have a headache, what happens? Nothing. Same thing with these medications. You do not get weight loss with at least not significant weight loss with these medications unless there's an underlying metabolic issue at play.
Wow. Okay. So I hadn't even thought about that. So I I want you to explain how they work so then people can understand also the difference between the semaglutide and the tirzepatide.
Okay. So there's actually 4 different GLP-1. Well, there's 6 altogether, but there's only 3 that have been approved for weight management. So the Ozempic, Mounjaro, and Victoza were all developed for diabetes,
Right.
and they were developed to be lifelong. And then their weight management versions are exactly the same medicine. They're not any different. They just have a different brand name. And that is Saxenda for Victoza, Wegovy for Ozempic, and then Zepbound for Mounjaro. And the way these medications work is they essentially stop the way our body makes fat. Our body makes fat when we eat carbohydrates, gets broken down into blood sugar. Blood sugar tells our brain, okay, I've eaten. Now, if you have a condition where you have glucose dysregulation or you have some issue with blood sugar, even way before you become diabetic, the brain doesn't get that message. So it just says, keep eating, because I'm not getting that sugar that I need to tell me that you've eaten. And so our body says, okay, well, I'm going to push up insulin, which is the hormone our body uses to get that glucose, that blood sugar into cells. Well, the problem is that that's not working either. It gets to the border of the cell and the cell's like, nope. And so it can't get the sugar in and it can't get the hormone in to tell the sugar to go in. So that combination just starts this vicious cycle of raising blood sugars, more resistance, and that's what we call insulin resistance. So when insulin resistance happens, you have a lot of blood sugar and you have a lot of insulin in your system, and the body doesn't know what to do with it. And when our body doesn't know what to do, it makes fat. It's like, store this fat until I can figure it out. And that's essentially what happens. So the body gets really efficient at taking food and turning it to fat because the brain's no longer signaling properly. And that's actually how these medications work. They work in the brain, so the brain gets the right signal, so it stops appetite, stops you from craving food all the time. It stops the salty and the sugar or the starch and carbohydrate cravings that you have all the time. It stops what people call food noise. That noise is just like eat, 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 eat. It does all of that. But it also acts on the heart to preserve muscle. It acts on, inflammation, because sugar causes inflammation. So when it's, metabolized properly, our inflammation drops. There's just a lot of benefits. So all the benefits of controlling diabetes are now afforded to people before they even become diabetic, who are way down in the continuum. So we can prevent diabetes with these medicines and all the complications that come with it.
And heart disease, of course.
Mm-hmm.
And
Yes.
actually, Wegovy, they have now the FDA approved to treat heart disease,
Yes.
which is amazing. And then I heard just last week that they're doing research on one of them to do something with dementia, which
Yes. Mm-hmm.
blows me away
Yes.
because that directly affects our family. So that is really like, oh my
Mm-hmm.
God.
Yeah.
So
Fatty
that,
liver. GI doctors have been using GLP-1s for fatty liver for some time too. And addiction medicine physicians have been using GLP-1s to help people with addiction. It acts on the addiction centers of the brain. So,
okay.
so some people have addiction to food, and others it's to other things. But we're finding that people who are put on the medication for weight loss stop smoking, stop drinking, stopped using drugs. And so those are now it's becoming more and more acceptable to use for those reasons.
Okay. So the difference between tirzepatide and semaglutide?
So the difference between semaglutide or semaglutide, depending on who you ask, and tirzepatide is that there is the GLP-1 component, which is the glucagon-like peptide, and that is actually something that our body produces in our body naturally. And what that does is it helps the body regulate blood sugar. And just to put it simply, tirzepatide, which is the mounjaro and Zepbound version, also has what's called a GIP component. And that is, and I'm going to say it very slowly because it's a long name. So it's glucose insulinotropic polypeptide. Yeah, that's it. And so what that does is it also makes the body more sensitive to insulin so that your body uses it better. It actually helps, the simplest way of putting it, it helps block the blood sugar issues that stress hormone causes, cortisol, basically. That's the main benefit of it, and how we tend to use it or determine which one we're going to use, because that's the component that helps with that.
Okay, say it one more time.
So you have the GLP, which works really, really well. GLP-1, Ozempic, Wegovy have
Yep.
GLP-1. Mounjaro and Zepbound have GLP-1 and GIP. So the GIP, the way it acts is it is controlled by how much insulin is in the body. That's why it's called, glucose insulinotropic,
Got
basically. So when your insulin levels go up, and usually what happens without any medication, our body either makes fuel, takes the glucose we've eaten and makes fuel, or takes the glucose we've eaten and makes fat. One of the two. And so what GLP-1s do, it stops that fat production and it shifts it back to fuel like it's supposed to. When you have the GIP, it makes it so that the insulin doesn't even go up too high to make that even a distinction. It just stops it.
Got it.
So it automatically goes to fuel, doesn't even have to fight to make fat, and it actually starts reversing some of the fat production that's been made.
Got it.
But the only benefit of it is if someone's stress related weight gain. If their weight gain is related to cortisol, which then triggers a whole chain of events, including, cravings, including um, insulin resistance in and of itself. So unless that component is there, there really is no benefit between one or the other.
Got it. Okay. That makes sense.
Mhm.
So, and I mean, you're not pharma, but do you know if they've got it under control where now people don't have to, big borrow and steal to figure out where the drugs are located? Because, I mean, I know
Mhm.
personally that we've called so many pharmacies between two states, and I'm like, okay, somebody.
Yeah. Well, one thing that's happened is that Eli Lilly, that makes Zepbound, and
Mounjaro.
Mounjaro, are also making vial versions of their lower doses. It was usually the lower dose where people had a hard time getting. And so if they have vial versions, what that means is that it's easier for people to get longer supplies, but also it's easier to produce and get it shipped out when it doesn't have to go into a pen.
And okay.
Yeah.
So the
And
vial
now
means that you're gonna have to purchase
draw it
and use
up.
the syringes.
It's like insulin, just
Yeah,
like
and draw
insulin.
it up just like insulin. Yeah.
But it's not insulin, but then you do it and you use it in the same way.
Right.
Now, the other though is that there are others in development. And like we know, when there's a new kid on the block, everybody goes to the new kid. So
Right.
once that happens, there's going to free up supplies for the other medications. But I would like to take this opportunity just to say it is a media misinformation, I don't know, machine that has convinced people that somehow these medications being used for weight management are taking medications away from diabetics. That is not the case.
Right.
First of all, obesity is a disease and just as devastating as some of having a metabolic issue. And
Right.
usually they're the same. They're on the same continuum, just different places in that continuum. But the other is that if you treat one disease state, it does not mean that another one does not get treated. So if you're taking medication for pain and you have knee pain, that's not the person taking it for knee pain is not taking it away from people who have back pain.
Right.
That's just the nature of, so it's a supply issue. Excuse me. It's a supply issue, not a use issue. It was definitely in high demand, but they knew that was going to happen when they said it was for weight.
Right.
Because we live in a place in a time where there's always been toxic diet culture, not just with these medications, but always. We've
Right.
always had anorexia. We've always had people who would go to extremes to lose weight. And now they just have another tool to use. And unfortunately, that is being superimposed on the medication.
Right. And I'm glad you said that because there is a lot of people that are like, oh, and totally not true.
Yeah.
Um, and then, of course, the other piece of this, of course, is the insurance companies. I know personally, my insurance company was like, well, we don't cover weight management drugs. And I'll tell you, it's Blue Cross Blue Shield of Illinois. We don't
Mhm.
cover weight management drugs. We do cover diabetes medication.
Mhm.
So I made sure that they clearly heard me state. So you're
Mhm.
telling me that I am trying to take a medication to prevent myself from getting diabetes, but you won't cover that. But if I already had it, you would cover. And they
Mhm.
said yes. I said,
It's a
okay.
money issue.
And I said, okay, I just wanted to make sure we were clear. So
Mhm.
when open enrollment comes up and you notice your lifelong, because I had Blue Cross Blue Shield my entire life,
Mhm.
you notice that I've jumped ship. You'll understand why,
Mhm.
because this is an issue. I have a diagnosis of obesity.
Mhm.
I am 4'11". In one of those pictures, I could have clearly have been probably about 235, 240. Remember, I just said I'm only 4'11".
Yeah.
And so gracious to God that I did not have high blood pressure, did not have diabetes, not even pre-diabetic, didn't have high cholesterol, none of that. But I would have I'm sure one day it was coming. It just hadn't come yet. Thank the
Yeah.
Lord. But
Mhm.
especially because I have a family history of diabetes, of high blood
Mhm.
pressure, of high cholesterol. So I knew that these things were in my family. And
Mhm.
if I didn't do something about it, I probably would end up on medications just like the rest of my family.
Mhm.
Um, and so, and yes, I have lost weight, but I'm still, as you know, my
Mhm.
BMI is still not where it needs to be. We still have some pounds to go to get to the normal range. And Dr. Tumer has been so kind. I send her messages and she answers them. But she told me, she said, you know, a lot of chronic conditions occur when you are not in normal range with your BMI. And I know a lot of people want to argue the BMI doesn't apply to Black people for this and this and that. Be very careful when you say that, you know, we're
Mhm.
made differently and all this stuff. Be very careful
Mhm.
because, like she said, chronic conditions often lie when you are outside of the normal range.
Mhm. However, now there's a caveat to that. So yes, we tend to have larger BMIs because our muscle mass tends to be higher. Traditionally, that's not across the board. That just means traditionally. But that's only if you built that muscle.
Okay, so she's trying to tell you when grandma
Mhm.
told you you're a big bone, there is no such thing as big bone.
So this is the thing. Even if your BMI, whatever your BMI is, and you have it's what happens is when certain situations hit your genetics and those genes get switched on, you may or may not be able to switch them back off again.
Right.
And so what happens is, yes, maybe you feel great and your BMI isn't what's considered normal or healthy, but if your pressure is climbing, your A1C is climbing, and all your other parameters are climbing, I don't care what your BMI is, it is not healthy for you. Now, it
Right.
may be different for everybody, and it may not be, within what is considered medically normal. But if all other things are not normal also, then your BMI is too high.
Yeah. And you also, I mean, so BMI is the basal, what is it?
Metabolic index.
Metabolic index. Yes.
Mhm.
So basically it's a calculation you get when you put your height and your weight together,
Mhm.
and that's how they get this calculation. And the normal range is between 20 and 30, right?
No, normal range is between actually 18 and 24
Let's see,
is what we
18 and
consider
24.
normal.
See, I was trying to
And
get
see,
I'm
and
so
then 25 to 30 is considered overweight. 30 and above is considered obese. And then there's different classifications of obesity.
right.
Over 40 is class 3 obesity. Um, class 1 is 30 to 35. 35 to 40 is class 2.
Yeah. So I'm somewhere around 35. So I'm in the obesity category still. But we're working on it. It's coming down, it's coming down. But I think that people need to look at those things, and you know, and you can go and look up BMI calculator and figure out your BMI or whatever. And then I have an amazing scale, and I will make sure it's in the show notes. I love my scale. I have a Renfo scale that tells you way too much information, but at the same time, as my favorite philosopher Jay-Z says, numbers don't lie. So so I pay attention to numbers. I am a scientist, obviously, because I'm a doctor. And so I pay attention to numbers, and the numbers don't lie. And those numbers, as you've heard many times before, are very important. There's some very important numbers that you must know in your life. You got to know your average blood pressure. You need to know your cholesterol level. You need to know your blood sugar, your A1C. Some people have no idea. A1C is the truth teller. So you can go to the doctor today and say, I have been doing great. I've been eating less this and this and that. and they take your A1C, and it tells you for the last 3 months of really
What
what
your
you've
blood
been
sugars
eating.
are doing.
And like I said, it's a truth teller. That's going to tell them what you really have been doing and haven't been doing. And your A1C, you want less than 6, correct?
Actually, less than 5.6.
Less than 5. So,
5.6. Yeah. But
so
let me just say that the A1C, again, it's a good number, but it's an average. That doesn't mean you don't have high blood sugars. So what it's very important to see if there's a change. If you go from a 5.2 to a 5.4, yes, both of them are normal. But if you climbed, what that means is your body is not metabolizing sugar very well. So you can have a normal blood sugar, A1C, and still have metabolic issues.
mhm.
And that's where glucose tolerance test comes in and works to find out what is actually happening to blood sugars. And if you're spiking, which is when our body loves to make fat, you can find out by getting a glucose tolerance test.
And most pregnant women, you remember the glucose tolerance test. You went in, you drank that very, very sugary drink, and
Sugary
then they
stuff.
took your blood work. They took your blood shortly thereafter, and that's when they let you know if you do have gestational diabetes or not. But that's the glucose tolerance test that we're
Yes.
speaking of. Same exact thing.
Yeah, which
And
I
so,
had actually. Um, and which is, and that's partly why I had to stay on insulin, because that's the only thing you can use for a gestational diabetic. And when a woman's pregnant and diabetic, the only thing you can use is insulin, because nothing else is considered safe. But what happens, so normal, you want your blood sugars to be under 140 after you've had challenge, preferably under 120 or 70 to 100 if you're fasting. When I did my glucose tolerance test, mine went up to 400. Yeah, I was very squarely diabetic.
yeah, wow.
Yeah.
So yeah, you have to, like I said, these are important numbers you should know, because then you know how you're doing. Because there's a lot of people who walk in this earth that think they are just fine, but on the inside, they're not just fine. And that's how you hear about all these people who suddenly drop dead. Well, because
Mhm.
you didn't know your numbers, you didn't know things weren't just fine. And like you said about family, it's really, really, really important that you know your family history. I have friends that are skinny, healthy, they exercise, all this stuff, but they had a family history of high cholesterol, and they're on cholesterol medications
Mhm.
because they go to the doctor and they found out their numbers.
Yeah.
And cholesterol is really important because it can block your arteries. And if your arteries are blocked, then the blood can't get through. And that's where you have heart attacks and strokes. So come on, it's really important that we go to the doctor regularly so that we
Yes.
know our numbers, because there's a whole lot of people walking around that don't necessarily check their blood pressure every day, but have high blood pressure,
Mhm.
but don't
One of
realize
the things I hear a lot are, I want your help to lose. They come to me for help to lose weight because their doctor told them they're pre-diabetic and they don't want to become a diabetic, so they want to lose weight. And one of the things I say the reason that you're gaining weight is because you're pre-diabetic. You're not pre-diabetic because you're gaining weight. And so what happens during that phase before coming diabetes it's like 10 years of our body becoming this fat making machine. It is so efficient at taking food and turning it into fat, and our weight just slowly creeps up and up and up and up. And then our A1C slowly creeps up and up and up and up. And the only way to get the A1C down and your weight down is to go after the metabolic cause of the weight gain. Weight is a side effect of something else.
mm-hmm.
And so we always go after that something else. And the reason these medications, GLP-1s, work so well is because it goes after the number one cause of weight gain, which is metabolic glucose dysregulation. Our body makes fat out of the byproduct of carbohydrates, not from fat.
And
And
I mean,
that's something we
if you like breads and mashed potatoes and stuff like I do, then
mm-hmm.
you understand how these work and how great they are. I I think that I was in the audience when Oprah did her weight loss show, and I sat there and was listening to her. Was like, wait a minute, and it was like a light bulb went off. because they had obesity medicine physicians who spoke about how they worked. And I was like, and then she talked about how, I did great on Weight Watchers. I did great on Weight Watchers. And then she's like, and
For a
slowly,
minute.
like I was like, and slowly things started switching. And she was like, and I said, oh my God, I understand what she's talking about. Now I do also credit that my the way that I was working out before was not the same. I had done a little something in there and was like, okay, you got to get a grasp of your life again. And so now I'm back on the right path and stuff. So I knew that if I did that change, that would help. But why not try and see if these things helped? And I can tell you they work, they helped. And the
And it's
food
not
noise,
cheating.
it's not cheating
It's not
because I
cheating.
still eat like I have sense. And the other thing, when I did Weight Watchers, and even before I did Weight Watchers, I did this fast. I did a 90-day carb fast. I didn't have any carbs for 90 days. Try that. And and I did cold turkey. That was insane. But after that, my stomach had gotten so much smaller that I just couldn't eat as much as I used to. And I also started really listening to my body. So I would stop eating when I was full, which I don't
Yeah.
think I ever did in my life.
Well, that's exactly what I was talking about, the brain cues, the brain signaling. Carbohydrates are what tell our brain to signal or not signal. And so when you control carbohydrates, your brain signals become normalized.
Mhm.
And so your appetite does drop.
Yeah. And
And
so
so you stop eating as much.
I was like, but I really was listening. Are you actually
Mhm.
hungry or are you bored to tears and you just feel like you need to go eat?
Mhm.
Right?
And my thing is this: food is a self care mechanism, is something we have to do in order to stay alive. So it's just a matter of making certain choices that we can, the best choice we can within any given situation.
Yeah.
That also means eating out of boredom. I eat out of boredom. I've lost over 100 pounds and I still eat out of boredom. I still eat out of stress. I still eat, emotional eat. Because that's all. I mean, Thanksgiving is a whole day of emotional eating. So, we all do it, but it's what you do that matters, not that you do it. And one of the things that diet culture has done is that it blames who are essentially um, the victims of their own physiological hijacking,
Mm-hmm.
because that's essentially what it is. If you take two people and you give them the exact same meal, two different things will happen to that meal once it hits their body. One person could easily make fat, and the other person only makes fuel. And so when we have people who eat whatever they want and they remain thin, we always say, oh, yeah, they have good genes. But it's the same for the person who can eat very little and gain weight. When I weighed 220 plus pounds, I stopped weighing myself at 220, but I'm sure I went up. I ate far less than I do now at 113. I eat
Wow.
way more now.
Mhm. And I will say, I I think that, just like I said, numbers don't lie. So therefore, I paid attention to, like, okay, in my head, I'm like, okay, I'm not really hungry. I need to go drink some water. I need to go do something else. And that made a huge difference. And so even now, um, I stick to that still. I'm like, okay, you
Mhm,
just don't need to just eat for the sake of eating. You need to eat because you're actually hungry, and
mhm.
use it as
But it's
fuel.
easier to do that when your brain is sending out the right signals.
Exactly.
So your behavior and your brain are connected. So yeah, you can listen to your cues and not eat when you don't have your brain saying eat more, eat more, eat more, eat
Right.
more, eat more, because now your brain signals are being regulated like they're supposed to. And so one of the things that using GLP-1s has made it very, very, very clear is a lot of our behaviors were driven by our biology, not the other way around. And
Yeah.
so that is, and not saying making excuse people like, oh, you're just making excuses. No, but if you know that if you poke somebody with a knife, it's going to cut them, then you stop poking them with the knife if you want them to stop being cut. It's the
Right.
same thing with this. If you know that our brain is what's driving your appetite, then you fix the thing that's doing it, and that's glucose dysregulation. And that's why these medications work. And They don't work. I mean, people talk about Hollywood movie stars and they're using it. First of all, statistically, population of celebrities in this country are so small. I mean, statistics, they can't buy enough to cause a problem.
Right.
The other is, and of those people, not all of them have glucose dysregulation. So they're going to use a medication. They might lose 5-10 pounds, but not much. And the reason is that's only the mechanical part. There's one part that slows gut motility, so it makes you get full faster. That is the only part that acts locally and not centrally. And so if someone who doesn't need it takes it, they aren't going to lose much weight.
And I mean, I've heard stories, I'm sure everyone, it was on the Breakfast Club recently. Candy Burris apparently took, I think it was wegovy. She took it and it didn't do anything, didn't work for her. Her doctor was shocked. They tried different dosages and it just didn't work for her.
Yeah.
So, and so
I mean, the thing is, wegovy doesn't work for people for a couple of reasons. It doesn't work for people whose metabolic process is not the cause of their weight gain, or if their weight gain is caused by stress. If they are stress related metabolic, if they're metabolically sensitive to their stress, wegovy is not the best choice.
Oh, they needed tirzepatide. I got you.
Exactly. And so, and the other is, if someone has been a serial dieter their whole life, and that's someone who's done the diet after diet after diet after diet, lost weight, gained it, lost weight, gained it, lost weight, gained it. You've also lost muscle during that time. So you've lost the one thing that gives you your metabolism, and that's your muscle. So by the time you get to a point where your body has just really been efficient in making fat, your muscle isn't enough to help the process. And so the medication only works so much. And that's why we always talk about eating protein and doing muscle work, because that determines what happens next.
Gotcha. And so that's what I was going to say. The other thing is, it's not cheating because you have to still work out. You have to eat sensibly. And I'm an 80-20 person. You know, I'll eat whatever. I eat whatever I want.
Mm-hmm.
I just know when to say when, and I don't eat it every day. So my birthday is next week. Mm-hmm. And so for my birthday, I will probably indulge in pound cake. And God willing, I can find my pink bubblegum ice cream from Baskin Robbins. And those are my two things that I must have. And if I have those two, I'm really happy. But I usually just eat my 31 flavors, that pink bubblegum, I usually eat it for my birthday, and that's it for the whole year. I'm not big on ice cream, period. But pound cake, it tends to be a holiday kind of thing with our family. So I'll eat pound cake a couple times a year. But I purposely do not own a KitchenAid because I said I'd end up making them and eating them.
And that's the thing. You just know what your triggers are and you avoid them. But at the same time, you know, the process is what I call it's a biopsychosocial process. Medications hit the biological part. They actually even touch on some of the psychology as well, because our moods are controlled by our brain and blood sugar as well. Excuse me. Excuse me. But the social part is where the food making comes in. People make food out of love, and it's really hard when you don't eat it. And so if you're in a situation where your social interactions are changing because of a process you're in, that process is not appropriate.
Yeah. And so Golden Grams is another one of my friends. And when I tell you, I have literally not had Golden Grams all of 2024, and we're not done yet, but I'm going to try to hold on and not have it again until 2025. But I love Golden Grams, and I can kill some Golden Grams, but I know that that's a problem. So therefore,
just don't get them.
I just don't get them. And I bought cereal, and actually I hadn't eaten cereal in a long time. And that's my new little bedtime snack is eating either cornflakes or Cheerios or Crispix. That's my little thing with my oat milk before I go to bed with my stevia sugar. And that's just my thing. I just need some sugary when I go to bed, and that's what I eat. But I don't have the problem that I have with Golden Grams with those. Like I will eat a bowl or two and I'm done.
Yeah.
Golden
I mean,
grams,
if you just
fries,
know
I
your
eat the
thing
whole box.
and
Exactly. Exactly. Yesterday, instead of taking a few crackers out and eating them, I brought the whole sleeve and I had to stop myself because I was about to go
yeah,
through
you
that.
know,
And I was like, wait a minute, what are you doing? You're just
mhm.
sitting here watching TV and eating. I don't even know that I was tasting it really that much. So I was
Well,
like, oh,
that's there are lots of ways, like there are what we call non diet ways of losing weight, and there's different mechanisms you can do to protect yourself from the things that we know cause problems. One of them is distracted eating, so you're eating without paying attention to the taste, smell, crunch, whatever it is that you're eating. When we put all of our senses into our food and savor it, it changes what it does in our body than when we rush and eat it. And our brain works on messaging. So if all of our senses are sending a message to the brain that you're eating, then the brain gets the message and you're less likely to eat too much.
yeah. And that, I guess that's what I think is the best thing about them is that I know that I don't think about food all day. I eat when I'm supposed to eat. Um, and I mean, it's amazing to not think about food all the time. And I guess I
Yeah.
didn't realize I did until I didn't.
Hmm.
Because like
Most
when I say
people
I don't,
don't.
huh?
I mean, I think a lot of people who are walking around with some type of metabolic issue do not realize just how bad they're feeling until it goes away. It just causes a lot of problems, not just with fat production. We can see the weight go up or down,
Right.
but it's really the what it does to blood vessels, and what it does to small blood vessels in the eyes, leading to blindness, in the brain, leading to strokes, in the kidneys, leading to kidney failure, in the gut, leading to all sorts of inflammatory issues, in the heart, leading to heart attacks. I mean, these medications block all of that. They stop it. The things that are killing us are stopped.
Yeah.
As long as it's used properly, as long as it's monitored properly, and as long as the source is correct. One of the things I'm also seeing is everything being called Ozempic, like Band-Aid, Kleenex, whatever, whether it's compound or whatever, everyone just calls it Ozempic, which it may or may not be. So all complications are being assigned to Ozempic. All behaviors are being assigned. So every complication we see almost always can be traced back to a behavior that was inappropriate for that process. You know, if someone says they have gastric paralysis, so your gut becomes that's not subtle and that's not quick. It happens slowly over time. So what that means is a person ignored their symptoms for months before that happened.
Gotcha.
But people will ignore symptoms in the name of being thin. We'd never
You're right.
accept that for any other reason.
You're right.
You know, all the things that we're hearing about, all the complications, and I can tell you, I've been prescribing these medications for diabetics and for weight management for over 10 years. I've never seen a case of thyroid cancer, which neither have the pharmaceutical companies. That's only in rats. Never had a case of pancreatitis. The one case I did of pancreatitis was simply because the person's weight dropped so fast they got gallstones, and that's one of the drawbacks of losing weight quickly. Gallstones can, and the number one cause of pancreatitis is a gallstone getting stuck in the common bile duct. So yes, you do see a connection, but it's not the cause. And honest, I've never seen gastroparesis, paralysis ever.
Hmm.
And the thing is, truth be told, before we started using for weight management, nobody cared. There were no articles. There was no talking about it.
You're right.
We've been using these medications for diabetics for 20 years.
Yeah, I was surprised to see that what is it called?
Trulicity,
Trulicity is one of it's part of that family.
yeah, Trulicity is Byetta, Bidurian. Those were the old ones, like the first ones that
Right.
came out.
Yeah, I didn't know that. So
Yeah,
I was looking at it and was like, oh, it's part of the family.
yeah,
But
they're
it
all
also, I looked it up and I was like, you have to exercise and eat right with it too for it to work properly.
mm-hmm.
Yeah.
Well, see,
So
that's the thing. Um, it does work well on its own, but only for a time.
Mm-hmm, mm-hmm.
Um, when like I say, how you lose your weight is how you keep it off. And so if you lose your weight 100% using medication, then it's going to remain 100% medication keeping it off, which is okay if you're comfortable with that. However, if anything happens and you lose access to that medication, you have no backup. And so when it comes to weight, it's really important to have multiple streams of weight loss so that other parts can take over if something happens to one. If you're only losing weight through exercise and something happens and you have to stop exercising, then what else do you have? So you just have multiple ways of getting healthy and allowing your body to go where it goes so that if anything falls away, you have others to just kind of boost up in its place.
That I didn't think about that. That's very smart. Which is why you keep all the pieces together. And Oprah said she hikes, and so I run or walk in the morning, and then throughout the day I try to get at least 12,000 steps. Usually I end up with 16 to 20,000, but that's my thing. And then I have a trainer 3 days a week with strength training, and just doing that kind of stuff. So that, and then I eat like I said, I try to eat sensibly. And I'm really good. Like now, I'm really good about protein and a vegetable, and I'm like, oh, I forgot to start. So I'm really good at that now. But I know I need to up my protein. That's my biggest thing, because I'm like, as much as I love chicken and beef, but I can't eat a ton of it just because I physically just can't. I just can't.
Well, that's where beans come in.
Yeah.
And you can combine their grain green combinations, and you can look them up, that when put together create a complete protein. So that's how vegans and vegetarians maintain their protein, by combining like specific things that work well together. And you can there's a long list, and you can look it up. And the beautiful thing though is we have to talk about access, because not everybody has access to the medications,
right,
even when they need them. One of the things that some of us have the option of choosing our insurance. Not everybody has that privilege.
right.
So I choose mine based on what medications they cover, because I'm on several because of my heart and my diabetes. And so I make sure, and all of them have kept me alive for 23 years beyond where I should have been. So I'm not giving them up.
Right.
So there are alternatives, but because it's such a lucrative business, there's also a lot of abuse and people abusing those who are desperate. And so really what's important is advocacy, just using our voices to make sure that the medications that are life-saving are getting into the hands of those who actually need them.
Yeah. And so there are, there's lots of compound pharmacists out there, and some are better than others. You have to, work with somebody like Dr. Tumer, or someone that you trust that knows these compound pharmacists, because I had a friend that was supposedly taking wegovy, and it was wegovy with B12. Well, nothing was happening with the scale. But when she went for her appointment, her B12 levels were through the roof. So it's like, what was really in there? Was it really what was supposed to be in there? Because she definitely has the underlying metabolic disorder, and so I know that. And so she was like, and so sure enough, she switches over to the pens, and voila, things are working again,
Yeah.
So
Yeah. And it really just depends. I mean, there are some, like when there's a shortage, the FDA requires that the pharmaceutical companies give up their formula so that it can be made as a generic form. And that's what happened. So there are some that are FDA regulated manufacturing that's watched very closely, and they're regulated very closely. And those places do a really good job of creating a medication that is identical to what you get as a brand. But because it's unregulated, there are a lot of other people out there doing the exact same thing, and they're not being watched by the FDA, and they're not being regulated. And that's the problem. And it's really hard to tell if you're outside of medicine. It's kind of hard to tell which is which. Even if you're in medicine, I get a lot of requests asking me, what compounded pharmacy I use and how did I pick them. It took me 6 months to vet one.
Wow.
Because because it's so easy to get wrong.
Yeah. And I mean, and the price is what,
Mhm.
especially us, it sells us because, oh, it's so much cheaper at the compound pharmacy, but you just want to make sure you're getting what you're supposed to be getting.
Mhm. And the name. So this is the other thing. Whatever you're taking, whatever medication, know the names of your medication and the dose. Not, and it's like the number dose.
Mm-hmm.
Not I'm on the third one or
Right.
units.
Right.
I'm on this many units. That's not a dose.
No.
Units is not a dose. The concentration times the units is a dose. But if you don't know the concentration, knowing the units isn't going to tell you anything. And
Yeah.
it's important because we're getting a lot of reports of GLP-1 overdosing because people are not reading the labels properly
Oh,
for.
goodness.
And so what's happening is that people usually end up becoming so severely dehydrated that their kidneys shut down. Why anyone would have vomiting for 4 days before seeking help, mainly because again we're shamed about using the medication first of all, and then you make a mistake and it's like then you're double shamed, but your life is worth, I mean, who cares?
Right.
you know Stay alive.
Exactly. Exactly. So please tell people where they can find you so that they can possibly work with you. And I'm going to
The
try.
best place to find me would be on my website, drtoomer.com, which is drtoomer.com. The other is I have a YouTube channel, also Dr. Tumer, where there are over 100 videos that you can go and listen and watch. It's just across the board. So I do health, wellness, and weight care. So it's just information across the board. And every Tuesday at 6 p.m., I'm live on blackdoctor.org for the Dr. Tumer Talk Show.
Perfect. So everywhere she's Dr. Toomer, please go check her out. You want to definitely, her show is great. She gives great information. And you definitely would like to, if you are one of these people that your doctor said you're pre-diabetic, please don't take that lightly because there's a lot of people who don't pay attention to that diagnosis. And then the next time they go, they are diabetic and they are very upset because now, of course, they have this condition and they have to take medication and all this stuff. So why not try to do something about it beforehand? So
Yeah.
please, definitely, we'll have your information in the show notes. And thank you so much for joining us today.
Thank you for
The
having
Black
me.
the Black Doctors Speak podcast is presented by the African American Wellness Project, and you can always visit us for more information at aawellness.org. aawellness.org. I am your host, Ask Dr. Renee, and don't forget, you can always find me at Ask Dr. Renee at everything. And we'll see you next time. Thank you.